When I work in suicide prevention and people ask if it's depressing, and I say, no, it's not depressing at all, because hopelessness is depressing. There's so much more that we can do to help people so that they never feel suicidal in the first place. Suicide is the second leading cause of death among people ages 15 to 34, and every year there are twice as many suicides than homicides in the U.S. At CDC, we collect data, we research the factors that contribute to suicide, and we develop and test interventions, and then we get the word out. In suicide prevention, one of the things that we've been working on is changing the messaging. People feel embarrassed, ashamed to admit problems that they're having, feelings that they're having, and they feel embarrassed to go get help. But help is available and can help prevent suicide. I've seen depression and despair up close, and I've also seen people overcome those things. I go to work every day to bring people hope. I love my work and I love my job because it's a challenge. I am Deb Stone, and I am CDC.
Good afternoon, morning, or evening, depending on where you're listening from. I'm Dr. John Iskander. On behalf of CDC, I'd like to welcome you to the 6th anniversary edition of Public Health Grand Rounds. Continuing education credits for Public Health Grand Rounds are available for physicians, nurses, pharmacists, health educators, and other health professionals. Please see more at the Grand Rounds website. Grand Rounds is available on all of your favorite web and social media sites. We're also live tweeting today. Please use hashtag CDC Grand Rounds. Here's a preview of upcoming Grand Round sessions, including a special session in 2 weeks on global health security. Please join us live or on the web at your convenience. I'd also like to thank today's featured speakers and the many people who helped to make this outstanding session possible. We have several additional resources to accompany this session. Featured video segment on YouTube and our website called Beyond the Data. This month's segment features my interview with Dr. Alex Crosby. We've also partnered with the CDC Library to feature scientific articles relevant to this session. The full listing is available at the CDC Library website. Also on our website, we've posted suicide prevention resources from the Veterans Administration. Last Thursday, President Obama released a presidential proclamation reaffirming World Suicide Prevention Day and the belief that mental health is an essential part of overall health. This proclamation served to remember those we have lost and their loved ones, increase awareness regarding the reality of suicide and the importance of continued efforts to prevent suicide. To introduce today's session, I'd now like to introduce CDC Director Dr. Tom Frieden.
Thank you, John, and thanks to our presenters for being here today. Suicide may be the ultimate individual tragedy, but it's not just an individual tragedy. It's a tragedy for the family, for the community, for the country. It's the loss of potential. It is something that affects not just the current generation, but the future. And in that regard, looking at it as a public health problem is really critically important. For every one person who completes suicide, there are more than 200 people who have seriously considered attempting suicide. We're seeing increases in suicide rates in various groups around the U.S. We also know that suicide is potentially, I don't want to say contagious, but it does have an impact on those around them. And people who have a close order relative who's committed suicide are at higher risk as well. These numbers are perhaps the best example of this saying that statistics are people with the tears washed off. Suicide is a growing public health issue and an important one. If you look at years of potential life lost, it's right up there at the top or close to the top. If you look at impact on families, it's incredibly important and tragic. When you think about the different segments of society that are affected, whether it's veterans or middle-aged males or older adults or teenage kids, they all have specific challenges with suicidal ideation, suicidal attempts, and completed suicides. The researchers you'll hear from today have really helped advance our understanding of the trends and the potential impact of prevention efforts when it comes to suicide prevention. At the same time, we need to address two different aspects of suicide prevention. One are specific services for individuals at risk, mental health, substance abuse, and other services. Two, the broader contextual approach, addressing schools, daycares, parenting support, the workplace as an area for intervention, and much more, so that we're affecting not just the individual care context, but the broader community context within which a decision or ability to complete a suicide may occur. We're beginning to see areas where we're seeing progress in the reduction of violence and the reduction of suicide. The challenge is to learn more and to do more, to learn more about what works, to learn more about how we can scale up effective interventions, and then to do more in scaling up those interventions while attending to both the individual needs of individuals who are at risk and the community potential of strengthening the supports that would prevent suicide from occurring in the first place wherever possible. So thank you very much to all of our presenters. Looking forward to a very stimulating public health grand rounds.
Our first presenter is Dr. Alex Crosby.
Good afternoon. I will describe some of the epidemiology of suicidal behavior and several CDC activities in this area. The most recent complete death certificate data show that suicide is the 10th leading cause of death in the United States, responsible for over 40,000 deaths in the particular year. That represents about one suicide death every 14 minutes in the United States. Suicides result in an estimated cost of over $51 billion in medical and work loss costs. Examination of trends in suicide suggests that rates are going up. Since the mid-2000s, we have seen increases among middle-aged adults, those aged 35 to 64, shown in purple, and youth aged 15 to 24 years. Across age groups, suicide rates are higher among males and females, and males have a high rate of suicide that increases, especially after the age of 75. Female suicide rates are highest among the middle-aged years, especially during their 40s and 50s. The highest number and the highest rates of suicide occur among middle-aged adults aged 35 to 64 years. Among middle-aged adults, suicide is the 5th leading cause of death. In 2013, middle-aged adults accounted for the largest proportion of suicides at 54%. Since 2000, their suicide rates have increased nearly 30%. Youth are also substantially affected by suicide. Suicide is the 2nd leading cause of death among adolescents and young adults, and rates have increased significantly since 2007, with American Indian and Alaskan Native youth disproportionately affected. Like the general population, the suicide rate among veterans is on the rise. The suicide rate among veterans is higher than among civilians, both for veterans in general and among those receiving care in the Veterans Affairs system. Looking specifically at the Army, we find that age and sex-adjusted suicide rates began exceeding rates for the civilian population in 2008 and have continued to be higher. These trends have encouraged more research and program attention to suicide prevention among veterans and military personnel. Firearms are the leading mechanism for suicide, involved in over half of all suicides in the United States. Suffocation and poisoning, including drug overdose, are the 2nd and 3rd most common mechanisms. Mortality data severely underestimate the problem. There are many more individuals who experience suicidal thoughts and non-fatal suicidal behavior than deaths due to suicide. In 2012, data for adults aged 18 and older show that there were just over 39,000 suicides, over 129,000 hospitalizations, over 400,000 visits to emergency departments for self-inflicted injury, over 1.1 million self-reported suicide attempts, and over 9 million adults who reported seriously considering suicide. So for every 1 suicide among an adult, there were over 229 adults that seriously considered suicide, which demonstrates the large burden and the need for prevention. Suicide is a form of self-directed violence, and considering its connection to other forms of violence may help us to identify prevention strategies. Suicide has historically been addressed primarily as a mental health problem. This focus has proven too limiting because the majority of individuals with mental health problems do not engage in suicidal behavior. Conversely, the public health approach allows communities and prevention programs to address suicidal behavior as a multifaceted problem in need of comprehensive solutions. CDC's Division of Violence Prevention's strategic direction emphasizes the interconnection between multiple forms of violence. Experiencing a form of violence such as child abuse and neglect or intimate partner violence is associated with a significant increase in risk for suicidal behavior. A recent CDC resource, Connecting the Dots, describes how different forms of violence also share common risk factors. By addressing these common root causes, we have the potential to prevent multiple forms of violence, including suicide. CDC plays an essential role in the nation's efforts to prevent suicidal behavior by encouraging a population-level approach and greater attention to primary prevention strategies. Our surveillance activities directly inform prevention strategies by tracking trends and identifying subgroups and locations most affected. And the data are used to monitor the effects of prevention strategies. We support research to identify a broader range of risk and protective factors and the development and evaluation of prevention strategies. The National Violent Death Reporting System began in 2002 and currently operates in 32 states, as seen here in purple. It is the only state-based reporting system that pools data on violent deaths from multiple sources into a usable, anonymous database. These sources provide rich information on the circumstances of suicide. Linking information helps states and communities get a more complete understanding of the who, when, where, and how of violent deaths, and provide insights into why violent deaths occur to inform prevention. NVDRS helps us better understand and prevent suicide. For instance, data show that mental health issues such as clinical depression are associated with a number of suicides. The data also show that mental health issues are only one of many risk factors. NVDRS data identify other potential problems that might be addressed in prevention programs, such as alcohol or substance use issues. NVDRS data are also consistent with other research showing many factors put people at risk for suicide, such as intimate partner problems, financial problems, or legal problems. Knowing these risks helps us identify multiple opportunities for prevention. South Carolina used their NVDRS data to better understand the problem of youth suicide, identify communities in need of prevention, update their suicide prevention plan, and secure support for implementing suicide prevention programs for youth. These programs included evidence-based gatekeeper training to schools, public welfare and juvenile justice offices, and faith-based and community organizations. Oregon used their data to better understand its high-risk group of older adults. NVDRS showed that almost 50% of men and 60% of women above age 65 who died by suicide had a depressed mood before death, but only a small proportion were in treatment for their depression. Data also showed over a third had visited a physician in the month before their death, suggesting a possible opportunity for intervention. An older adult suicide prevention plan was developed and recommended a stronger integration of primary care and mental health services so that suicidal risk is recognized and older adults receive appropriate treatment. CDC is working with researchers to evaluate suicide prevention programs that focus on enhancing the protective factor of social connectedness. One project at the University of Michigan is called Let's Connect, which focuses on youth at elevated risk for suicide due to low connections with others or a history of bullying. This program connects teens with mentors to help increase the teens' involvement in community activities. Another project at the University of Rochester is called the Senior Connection. This strategy is designed for older adults who are socially disconnected or feel they are a burden on others. It pairs an at-risk seniors with peer volunteers in order to increase connectedness and decrease suicide risk. Next year, we will support 2 new projects that will strengthen our understanding of suicide among middle-aged men, how to reach this group, and the effectiveness of innovative prevention strategies. One way of preventing suicide is breaking down the stigma of talking about it and sharing knowledge. We are using a number of approaches, such as 1 photo, 6 words, which motivates participants to create images and select 6 action words to describe prevention. These images are posted on social media and have helped to bring attention to this issue as part of National and International Awareness Month. Each of us has an important role in preventing suicide and acting to prevent it. This includes noticing warning signs and giving support, such as helping people connect with resources like the National Suicide Prevention Lifeline. Public health has made significant contributions and can continue to strengthen surveillance and research to prevent suicidal behavior across the nation. Thank you. Our next speaker is Eric Kane.
Good afternoon. I'm pleased to be here today to share with you ideas regarding how we can prevent suicide and related forms of premature death, and what steps we need to take to advance science and practice. As a psychiatrist, and yes, I'm a psychiatrist at a public health setting, and the chair of a large clinical department, I can tell you that the traditional mental health approach, which seeks to detect at-risk persons or treat those who have survived their attempts, has not succeeded. Suicide rates continue to increase. Whenever someone's admitted to my emergency department following a suicide attempt, it's a failure. Just as admissions to the early ICUs did little to change mortality from vascular diseases. If we're going to prevent suicide at a national level, we must promote strategies that reach beyond clinic and hospital walls and into communities. We need population approaches, upstream, distal approaches that focus on behaviors and contextual factors that are common to many causes of premature death. Most suicide decedents share common risk factors prior to their death, as Dr. Crosby talked about. Common risk factors for suicide include alcohol and substance dependence, and alcohol use at the time of death, especially in youth and middle-aged adults. Other risk factors include financial problems, life stressors, physical health problems, legal problems, as well as early childhood adversities. Mental health issues are associated with most suicides. However, given the common nature of such conditions, they have no predictive validity. Common conditions cannot predict uncommon events. Thankfully, suicide is not yet common. Prevention strategies must be as broad as the risks they seek to mitigate. Like most public health problems, the risk extends beyond individual level factors. I've discussed several already, such as relationship breakups, legal issues. As well, we know that suicide rates are closely tied to problems in the broader economy, and research underscores that these can be buffered by national social policies and, in turn, reduce suicides. Data from CDC's Youth Risk Behavior Surveillance System show suicide risk factors often extend well beyond mental health problems. Among youth who have made a medically serious attempt during the previous year, 3 groups with different risk profiles emerge. While all experienced depressive symptoms, 2 of the 3 reported high to extreme levels of co-occurring substance use and interpersonal violence. Youth with these high to extreme levels accounted for over 70% of the sample, pointing to the interconnection of risks. Often, however, youth who are violent and using substances are not recognized for their suicide risks. Their numbers in school decline after age 16, when many drop out. Recognizing that such difficult to engage, acting out youth also are vulnerable for suicide underscores the need for broad-based prevention strategies. Now let me share with you a few promising examples that demonstrate that we can see reductions in suicide and other health problems with the implementation of broadly applied prevention strategies. In 1996, the United States Air Force began a comprehensive approach to prevent suicide among active duty personnel. It was a population-oriented strategy involving diverse partners and functional elements of the service such as medicine and mental health, public health, command, law enforcement, family advocacy, and financial counseling. The program's 11 components can be clustered into 4 areas, including increasing awareness and knowledge, increasing early help seeking, changing social norms, and changing selected policies. The strategy was built on the premise that preventing suicide is a problem for the entire Air Force family, not simply a medical or mental health problem. By strengthening both formal and informal social networks and changing policies and norms to encourage help seeking and help accepting, the Air Force was able to address risks that are common across many health problems. Ultimately, this became a violence prevention program as it achieved significant relative reductions in suicide and also homicide and severe family violence, as well as unintentional injury. In the years following the full implementation of the program, significant reductions in suicide were observed as depicted in the green box. In 2004, we saw an upward spike in suicide rates that was observed at that time and is depicted in the red box. An evaluation showed that the increase was associated with diminished or decreased implementation of program components. The detected drop in program implementation could have been related to a number of factors, such as 2 ongoing wars with a very stressed force that was under multiple command needs and decisions, or turnover of previously trained personnel as well as previously trained leaders, Once the program was vigorously reinstituted as measured in 2006, the suicide rate dropped again. Another promising comprehensive suicide prevention program is the Montreal Police Department. This multi-component program encourages officers to develop mutual support and solidarity and provides support to officers who have common problems, either at work or in relationship difficulties at home or in the community. Its components include a publicity campaign directed at officers, training for personnel and supervisors, and provision of prevention resources. After the implementation of the program, Montreal saw a 79% reduction in suicide rates over a 12-year follow-up period, while police in other parts of Quebec experienced no significant changes in rates. The Good Behavior Game is a different kind of program that shows promise. It's a classroom-based behavior management program, a strategy for elementary school teachers to use along with standard instructional curricula and methods. It was not designed as a suicide prevention program. Rather, it focuses on teaching children to control their emotions and to work and to play with others. Its core components include classroom rules, team membership, self and team behavior monitoring, and positive reinforcement of those behaviors. It's primarily designed to reduce aggressive, disruptive classroom behavior. Again, it's not a suicide prevention program, but it is targeted towards how people use their emotions. The program has demonstrated long-term reductions across multiple health outcomes, including antisocial behavior, smoking, drug, and alcohol use. This was spread across the schools. It also demonstrated, most importantly for us, long-term effects on suicide attempts. Young adults between the ages of 19 and 21 who participated in the program during elementary school were significantly less likely to report suicidal ideation and attempts throughout childhood, adolescence, and young adulthood. Even after 16 years, participants reported half the lifetime rates of ideation and attempts compared to matched controls. These results require replication. Yet they also demonstrate that upstream prevention can lead to broad-ranging, long-lasting effects. Programs to increase social networks and social support are also beginning to emerge and show promise. One example is Sources of Strength, a school-based universal suicide prevention program that enhances protective factors across the entire student population. It builds ties between trusted adults and peer leaders, and together they conduct well-defined messaging activities intended to change peer group norms. The program seeks to increase the acceptability of help-seeking, improve communication between youth and adults, and develop healthy coping attitudes among youth while reducing the acceptability of suicide. An initial randomized controlled trial with 18 schools in Georgia demonstrated improvements in peer leaders' connectedness to adults and with school engagement. Some of the largest program benefits were observed in perceptions of adult help for suicidal youth. A second randomized controlled trial is currently underway and includes approximately 14,000 students and will measure its impact on suicide attempts. Our understanding of promising prevention strategies serves as the foundation on which we have built the CDC-supported Injury Control Research Center for Suicide Prevention, a joint venture of the University of Rochester Medical Center and the Education Development Center. It has been created to be a center without walls, a generator of collaborative and sustainable research, education, and prevention efforts throughout the United States, which seeks to inform the field of suicide prevention by drawing on public health approaches at the state, regional, and national levels. We focus on upstream preventive approaches that reach across the life course and involve diverse communities. We address known risk groups such as middle-aged adults. We also examined conditions such as intimate partner violence, which can serve as focal points for innovative preventive efforts that are upstream and change lives. We also are using social media to define and reach marginalized risk groups that so far have been outside of what we can do with traditional methods. The growing evidence base demonstrates that we can effectively reach broad segments of the population and achieve great benefits. Suicide prevention is a wise investment. Many of the promising approaches demonstrate impact on multiple health risks, including family and community violence, substance use, and adverse school outcomes. Some people look at the risks for suicide and related premature deaths and believe that prevention is too hard. I remind you that at one time, we thought the same thing about reducing alcohol use and smoking and preventing HIV transmission in the United States. Once public health became a vocal leader and implemented broad strategies for these issues, the attitudes, knowledge, and behavior of the nation changed. Preventing suicide requires the same far-sighted, broad array of public health action, advocacy, resources, and efforts. Working together, we can make significant strides preventing suicide and promoting a healthy nation. Thank you. Our next speaker is Jared Heinemann.
Hello. My name is Jared Heinemann. I direct Colorado's Office of Suicide Prevention, and I'm the public co-chair of the Suicide Prevention Commission of Colorado. Today, I'll describe Colorado's efforts to use data to inform suicide prevention priorities, and we'll describe several public health initiatives to prevent suicide and factors that contribute to suicide in Colorado. In 2014, 1,058 Colorado residents died by suicide, a record high number. Typically, the suicide rate in Colorado was 40 to 50% higher than the U.S. rate. In Colorado, suicide is the 7th leading cause of death for all ages and 2nd leading cause of death for those ages 10 to 34. Like in the U.S., men of a working age, those ages 25 to 64, account for the highest number and rate of deaths in Colorado. Among females, those ages 45 to 54 account for the highest number of female suicides. These data reinforce the importance of prevention focused on the middle years. Colorado is home to many at-risk groups, including active duty military and service members and veterans, American Indian youth, lesbian, gay, bisexual, and transgender youth, working-age men, and a growing older adult population. White, non-Hispanic Coloradans account for 69% of our state's population and have the highest suicide rate than any other racial or ethnic group. All these at-risk groups are contributing to the state's higher than average suicide rate and help us understand where prevention is needed. All of Colorado's 21 health statistics regions have suicide rates that are higher than the U.S. rate. 5 rural and 1 urban region have suicide rates that are significantly higher than the rest of the state. However, in 2014, 81% of suicide deaths occurred in Colorado's 12 urban counties. Colorado's diverse landscape, with the state split from north to south by the Rocky Mountains and large rural and frontier regions, presents unique challenges to developing and implementing statewide initiatives. As a result, a thoughtful examination of all data prior to program development and implementation is required. In 2015, the Colorado Department of Public Health and Environment released Shaping a State of Health, Colorado's plan for improving public health and the environment. Mental health and substance abuse is one of 2 flagship priorities. The priority includes reducing the burden of depression in Colorado by improving screening and referral practices and reducing the stigma of seeking help for depression, particularly among pregnant women, men of a working age, and individuals who are obese. Strategies include improving screening and referrals and increasing help-seeking behaviors by middle-aged men. Goals include increasing the number of Colorado visitors to mantherapy.org to 125,000 by 2019. Man Therapy is a suicide prevention and mental health website designed specifically for men, and I'll describe it a bit later. The mission of the Colorado Office of Suicide Prevention is to serve as the lead statewide entity for suicide prevention efforts. Colorado is one of only 4 states currently with set-aside resources for suicide prevention. We collaborate with communities to reduce the number of suicide deaths and attempts through the provision of community grants, by focusing on highly impacted parts of the state and high-risk populations, increasing knowledge about suicide risk and prevention resources, training individuals to recognize and respond to signs of risk, increasing men's comfort with reporting mental health needs, and focusing in part on primary prevention. In 2014, the Suicide Prevention Commission was created to serve as the interface between public and private sectors in establishing statewide suicide prevention priorities that are data-driven and evidence-based. Along with traditional suicide prevention partners, mental health and public health partners, non-traditional partners were written into the statute. Appointed members include representatives from private business, agriculture and ranching, faith-based groups, the oil and gas industry, law enforcement, and an active duty member or veteran of the U.S. military. In its first year, the Commission identified 3 priorities and established work groups to develop strategies and associated recommendations. In July 2015, the Emergency Services Work Group approved a follow-up pilot designed to connect individuals who have attempted suicide with follow-up support and guidance telephone calls in the days and weeks after discharge. 4 Colorado hospitals will participate in the pilot and will partner with Rocky Mountain Crisis Services, our statewide mental health crisis hotline provider, to enlist at-risk individuals into the program. Man Therapy is an online resource designed to change the way men think and talk about mental health and suicide by using humor and straightforward communication to engage men who are resistant to help seeking. The project's initiative and direction was supported by data from the CDC-funded Colorado Violent Death Reporting System. The main goals of Man Therapy are to create social change among men in the general population about mental and overall wellness, to empower men and increase their help-seeking behavior, and long-term to reduce suicidal thoughts and deaths among men. Since we launched in July 2012, mantherapy.org has been visited more than 500,000 times and from every state in the U.S., and that's with 0 marketing dollars outside of the state of Colorado. More than 80,000 visitors have completed a self-assessment survey, and the University of Maryland at Baltimore was just awarded CDC funds to evaluate Man Therapy's impacts on men's beliefs and behaviors over the next 4 years. Because several mass and high-profile homicides have occurred in the state of Colorado, many think firearm violence is predominantly an interpersonal violence issue. However, firearm violence in Colorado is really a suicide issue. In fact, 78% of firearm deaths in Colorado are suicides. In an effort to raise awareness of the risk for firearm suicides, Colorado's Office of Suicide Prevention is working with state and national partners to examine and educate around lethal means among at-risk youth. One collaborative effort is the Emergency Department Counseling on Access to Lethal Means project. The team developed, piloted, and evaluated the Emergency Department Counseling on Access to Lethal Means training at Children's Hospital Colorado in Denver. The 1-hour online training instructs emergency department clinicians how to counsel the caregivers of youth being seen for a suicide attempt or suicidal behavior on how to remove and/or safely store firearms and lethal medications in the home. The conversation with caregivers is designed to take approximately 5 minutes. All clinicians in the psychiatric emergency department at Children's Hospital were trained and adopted the program as a standard practice with all suicidal youth. The program also purchased and offered lockboxes to families for the safe storage of medications. 89% of eligible families received the program, and at follow-up, most recalled receiving the information, and more than 90% found the intervention respectful and clear. The majority reported having unlocked medications in the home prior to the youth's emergency department visit. This decreased to less than 25% at follow-up. While only a small percentage of parents or guardians reported having unlocked guns prior to the ED visit, none reported having unlocked guns at follow-up. The clinicians reported the program was an improvement over prior practice and noted that the training and script with key talking points were well liked. These pilot data are promising and the team is committed to replicating and expanding the program, and in fact, this is an Office of Suicide Prevention priority through 2020. Identifying and addressing risk and protective factors common to multiple forms of violence can make our prevention strategies more efficient and effective. Promising programs like Sources of Strength that focus on these shared factors enable us to have a greater impact on overall health. Colorado partners believe this program's activities that increase student school engagement and connectedness to a caring adult could reduce multiple forms of violence, including suicide and sexual violence. Over the next 2 years, we'll be piloting and testing Sources of Strength in 7 Colorado schools. We've already learned a lot from the early stages of Colorado's suicide prevention activities. For example, using available state data helps identify priorities as well as gain support from key partners and the general public, which is important to enabling greater attention and increased support. It is imperative to engage key leaders to help adopt and advance key initiatives and to ensuring good monitoring and program impacts. We have also seen the value of taking smart risks and trying new ideas to engage at-risk groups. Implementing primary prevention approaches that engage people well before a crisis is crucial to taking a public health approach to suicide prevention. And like all public health problems, preventing suicide requires a long-term perspective and documentation and celebration of incremental changes. Leadership at the state and local level is critical and strong in Colorado, and it brings attention to the significant role public health has in working collectively to prevent suicide. Thank you. Our last speaker is Jerry Reed.
Good afternoon. Having worked in suicide prevention for nearly 20 years, my objectives are to convey that suicide is preventable and to share the significant progress made since our nation began discussing suicide in the late 1990s, which can propel the critical work still ahead of us. 20 years ago, suicide as a leading cause of death was largely unaddressed. Suicide was seen as a private matter between providers and patients. Our national approach followed primarily a mental health model and lacked a public health perspective or framework. Prejudice prevented us from openly discussing suicide, which deterred help seeking. Even when help was sought, effective treatments were sparse and clinical training was rare. There was little capacity, public policy, or funding focused on prevention. In the late 1990s, change began. Senator Harry Reid and Representative John Lewis each introduced resolutions calling for suicide to be addressed as a national problem and for the nation to develop a national strategy for suicide prevention. Then Surgeon General and former CDC Director, Dr. David Satcher, released the Surgeon General's call to action to prevent suicide. The first national strategy for suicide prevention was released in 2001. Our nation began this journey of addressing suicide as a serious public health challenge. We established a National Suicide Prevention Resource Center and a National Suicide Prevention Lifeline, allowing callers around the nation to call one number to be seamlessly linked to a crisis center. To date, 166 crisis centers across the nation participate in this network and have answered 7 million calls. Last year, nearly 1.4 million calls were answered for those in need. In 2010, a public-private partnership known as the Action Alliance for Suicide Prevention was launched by the Secretaries of Health and Human Services and Defense. The vision of the Action Alliance is a nation free from the tragic experience of suicide. The mission is to champion the cause of suicide, catalyze efforts, and cultivate resources to advance the national strategy for suicide prevention. To date, the Action Alliance has partnered with over 200 organizations. CDC leadership has played an active role in the Action Alliance. The goal of the Action Alliance is to save 20,000 lives over 5 years. One way to reach the goal is to develop a map of suicide decedent subgroups and where or how their deaths occurred. This is a way of thinking about who we need to reach and what settings to deploy interventions. These circles could overlap, such as a veteran who is in college as a student and was seen in an emergency department before death. In 2012, the revised National Strategy for Suicide Prevention was released. 2 years later, a prioritized research agenda for suicide prevention was launched. Among its aims were to support saving 20,000 lives by focusing on needed research. The prioritized research agenda outlines 6 key research questions. For each question, summaries are provided about the state of the science, what we need to know, and potential benefits of addressing the questions. Other progress by the Action Alliance partners includes adding vital information to build infrastructure and capacity, as well as convening executives from the railroad industry, the media, and health plan providers to inform suicide prevention efforts. Our work has shown the importance of a comprehensive approach and the necessity of active partnerships to save lives. There is no simple explanation for suicide, and thus there is no simple solution. For example, while we have tools to identify those at risk, we must also have sufficient number of providers to refer those at risk to, and those providers must be trained in delivering effective therapies. We have learned that a one-and-done approach is simply not effective. In general, prevention science tells us that more effective efforts use a combination of strategies that work in sync. The model on this chart shows a range of strategies that the best available science suggests can have an impact on suicidal thoughts and behaviors. Together, these represent a comprehensive approach that is systematic, data-driven, and in alignment with key problems and assets. These strategies should be part of an interconnected suicide prevention system rather than solitary efforts. 3 major national priorities connected to the National Strategy to Suicide Prevention include transforming the healthcare system, such as with the Zero Suicide Initiative, changing the conversation about suicide to encourage safer ways to talk about suicide, and implementing programs focusing on youth suicide and early intervention in states and tribal communities and on campuses. Goals of the National Strategy for Suicide Prevention include promoting suicide prevention as a core component of healthcare and implementing effective clinical and professional practices for assessing and treating persons identified as being at risk for suicidal behaviors. Zero suicide is a systematic, quality improvement approach that includes identifying and assessing risk, using effective approaches, and providing continuous care and support. Key organizational elements include leadership, workforce development, and a commitment to continuous process quality improvement. One behavioral health organization that has been implementing the model over the past 18 months has seen its suicide rate go from 3.1 to 1.5 per 10,000. If we could adopt and widely spread this approach in similar settings, we may save many lives. Another goal of the national strategy is changing the conversation about suicide, such as with guidelines to media on how to safely and appropriately report on suicide. Recommendations for reporting on suicide have also been developed in the United States and include informing the audience about suicide without sensationalizing, provided crisis line numbers and including warning signs and what to do if the signs are noticed, reporting on suicide as a public health issue and seeking advice from suicide prevention experts rather than seeking quotes from first responders or police about the causes of suicide, and using the most recent data and non-sensational descriptors of trends or group differences. Media guidelines have been implemented elsewhere and show the promise of this strategy. In 1987, the Austrian Association for Suicide Prevention implemented media guidelines. As illustrated by the tall vertical dotted line, this implementation was followed by a decrease in the number of suicides. The Garrett Lee Smith Act has helped to propel the implementation of programs for high-risk groups such as youth, students, and tribal communities. This was the first legislation to provide funding specifically for youth suicide prevention programs. Counties implementing Garrett Lee Smith programs supported training and have been shown to have significantly lower rates of youth suicide in the year after implementation as compared to similar counties where no supported trainings occurred. It is estimated that 427 deaths were avoided during the study period. This being said, no significant differences were seen in mortality rates 2 or more years after trainings were implemented. This points to the need for sustained suicide prevention efforts beyond the duration of a training program. Progress is being made. Every state has a suicide prevention strategy and has received a Garrett Lee Smith training grant. 32 states participate in the National Violent Death Reporting System, which is providing data that is directly informing prevention strategies. 8 states, supported by CDC's Core Violence and Injury Prevention grants, include a focus on suicide prevention, and over 30,000 clinicians have been trained in assessing and managing risk. While things are improved today, there is still much to do in terms of scalability, sustainability, evaluation, and research, and demonstrating impacts on suicide. When we invest in discovery, we can have significant impacts on health. As illustrated here, prioritization of public health strategies to address leading causes of death results in substantial declines in premature death. Suicide is one area where investment is low and death rates have risen. More suicide prevention research and public health action can help us save lives. We've had impressive results when we have invested in health concerns. We should do nothing less for suicide prevention. While we can celebrate important steps that have been taken, for real progress to occur in this still young field, we must invest in discovery. In the years ahead, new discoveries and wide-scale adoption of effective programs will help us along our path to saving 20,000 lives. By investing in best practices and sustaining these approaches, we can achieve real cost reductions and improve health. Strengthening our engagement with individuals affected by suicide and using data about suicide risks can help us implement comprehensive strategies. We must move beyond individual approaches to broader system transformation. Every door should be the right door, and good care should not be left to chance. We need to help communities understand suicide and the prevention steps they can take. Greater investment in research, scalability, and sustainability can help us achieve national reductions in suicide. In closing, let me quote Goethe: "Knowing is not enough, we must apply. Willing is not enough, we must do. The time is now, and real progress is within our reach." Thank you.
All right, we have concluded the formal presentations, and now we're going to open it up for questions and answers. Let me remind and encourage you that we would like brief questions. I know a lot of you have a lot to say. Hold your commentary, ask your brief question. I think that we will go with Susan Laird and some of our comments and questions that came in to us.
Yes, from our online audiences. Could the presenters please address childhood suicide? We have had several suicides recently aged 9 to 14 and would like to hear their thoughts on investigating, addressing, and preventing these in the future from the perspective of family, friends, and community. Sense-making is difficult with any suicide, but especially difficult when the decedent is a young child or teen.
The sorrow around suicides among youth is just beyond words. It's very difficult. Some communities have put together teams of people to investigate these, and it's very important that this be looked at from all aspects. I'm not going to try to give an explanation of any particular suicide, but it's clear that when you see several children dying, it's necessary to do some soul searching at a community level, not so much a family level, but at a community level, and ask what are the circumstances, conditions, and protective factors that weren't enforce or working there. Very, very evident is that we know that many children suffer adversities that are not readily apparent outside the home or outside the community, and it's really important to look at those and try to understand those, and they may be of a very diverse nature. And so coming to terms with that, learning about that, and then instituting change and protection is very important.
I'll add on just to that too, and one of the things that the Division of Violence Prevention has been involved with is providing epi-aids, and these are technical assistance, epidemiological assistance to communities that have had groups of clusters of suicides among adolescents, and we've been able to go and help out several communities in terms of looking at what are some of those risk factors. And I think as Dr. Kane mentioned, you oftentimes find that there are multiple ones that you look and you find that there are risk factors that exist at the community level, at the societal level, at the family level, and trying to address those and helping to make recommendations to those communities. And we've seen in several places where communities have taken those recommendations, added on some of their own knowledge, and been able to decrease suicides in that population. All right, no one else at the microphone just yet, so we'll see if there's others.
We do, from our online audiences again. What resources exist showing ways to limit the effects of stigma of mental illness on health professions, students, and trainees? Excuse me.
Maybe I'll start off and then allow some of our other panelists to mention. We've definitely seen, looking internationally, that there have been countries that have developed anti-stigma campaigns. Australia is one, other countries in Europe that have been able to specifically address some of the stigma, not only within the population, stigma especially against help seeking, but they've been able to do that and also address some of the issues that even clinicians may have in regards to being able to better treat, be able to better deal with those that might be experiencing mental illness.
It sounded in your question like you were talking about stigma among health professionals. And one of the things that's very clear in medical school education, as an example, nursing education, social work education, psychology training, is the whole notion of both helping people become more comfortable dealing with individuals who sometimes have frightening mental disorders. And stigma and fear are closely related, of course. The other is that helping health professionals learn how to seek health and help for themselves is a very important way of addressing the fact that either within themselves or their families there are many mental health and substance use problems, and it's important to know how to take care of these. And in doing so, know how to reach out to the people that they serve, whom they serve, in order to be more effective in their day-to-day activities as professionals.
And I would just want to add, if I might, that the Action Alliance for Suicide Prevention has chosen a priority of changing the conversation. I think we so often present the data, and the data is tragic when you see it, but what we don't present as frequently is the stories of hope, resilience, and recovery. And I think the more we focus on these are challenges that we face, whether they be of the body, whether they be of the brain, and they're all preventable, they're all quite treatable. We have wonderful practices that once applied can save lives and restore people to a positive path in their journey. And I just think we have to be cognizant of how important it is that all of us change the conversation to make sure that we don't allow this issue alone to sit in a place all by itself. It's a struggle like any other any one of us might face.
And we have several folks at the microphone and only about 5 minutes, so let's see if you can go quickly.
Thank you for your presentation. I'm curious to know whether there's been any studies showing the contribution or the association of the legalization of marijuana to this problem, if there's been any studies showing that it does or does not have a contribution, and many other states are looking at Colorado as a place where, testing a lot of these issues.
Yes, indeed. So thank you for the question. I should have anticipated that, and I didn't. No, so it's a really great question, and the reality is we don't know the answer to that yet, but part of the money that is being set aside from the sale of recreational marijuana is to advance the science. And so these are the questions that will be asked, and I think we have some early data now that I'm not familiar with, But over the years, it'll be a priority for us to see what the impacts are on the legalization of recreational marijuana.
Very good. Next question.
Thanks. Great suite of presentations. My question is about how the U.S. rate compares to rates in other developed countries. And beyond means control, what are other countries doing to, to prevent suicide?
Well, I'll start off with. Just recently, actually just last year, CDC collaborated with the World Health Organization to put together a document talking about preventing suicide around the world. And as part of that document, we talked about the epidemiology of suicide around the world. Some of the highest countries in terms of suicide rates are some of the ones from the former Soviet bloc, Latvia, Estonia. The United States tends to be about the middle in terms of Western industrialized countries. China has for a long time been one of the highest countries, although their rates have come down. They are unique in the sense that, we talked about, males having suicide rates about four times higher than females. In China, females had some of the highest suicide rates, and that contributed to it. The United States about the middle of the pack.
Yeah, I'll make a couple of comments. I go to China often, and actually in China, means control has been very important because the attempt rate is probably no higher than the United States. What was really striking about females in China, women in rural areas from teens to their early 40s, was when they did an ingestion, they didn't take pills in the medicine cabinet, they took agricultural pesticides. As they've changed the pesticides, as they've gone to second and third generation pesticides, what they've seen is that together with more emergency services, they have a lower death rate. So the case fatality rates changed. That's one approach. You take something like the UK, which has had a tremendous amount of success, and they've really worked very hard on things that, akin to what Jerry was talking about in the Zero Suicide Initiative. When people touch the health system in one way or another, they've instituted policies and monitoring of those policies and their implementation. So it's not what you expect, it's what you inspect. And the follow-up of people who've come to health systems and had suicidal behavior of one sort or another has really been very intensive. The more the policies are implemented, they've shown a direct relationship between the greater fall. The other thing I'd point out in the Air Force was they did not limit access to firearms. Now, the Army has recently, in some of its work, but the Air Force instituted its program of suicide prevention without, at that time, limiting access to firearms. And one of the lessons there, and people say, what were the active ingredients in the Air Force? And ultimately, it was really the whole was greater than the sum of the parts. That they had a full court press across the whole culture, across the whole system, informal and formal both. And this really changed attitudes and knowledge and behaviors as much as means restriction. So depending on the niche, the culture, it may be means control, but it also is creating a culture of safety. And in the United States, we know that that's going to be one of the most important things, is how do you create a community of culture of safety? So whether it's gun storage and the kinds of things that would calm, or lethal substances, alcohol, substances of, toxic substances, poisons, and other things.
Good. I think we may have time for the last two.
Okay. Dr. Kane, you mentioned the use of social media to reach marginalized groups, and I work in South Dakota on the Rosebud Reservation and have connected with Pine Ridge. And I know that right now, in addition to some of the texting programs in South Dakota, they're using Facebook to connect youth to each other. And I'm wondering if there are any guidelines out there so that it can really meet its purpose of creating that healthy community, rather than becoming something that kind of feeds off each other. And I just want to know, I guess, what are the safe guidelines for Facebook use?
Well, Facebook, to their credit, has been one of the most active social media companies in trying to develop tools online for participants to contact each other and really talk about peer norms that are safe norms. One of the things that we've been talking about, indeed, is the development of a conference, in part sponsored by CDC, that looks at social media and also talks about the ethical issues and the challenges and the questions of what's effective. Trevor Space in LA, the Trevor Project in LA for LGBT youth, has started to use social media as a tool to engage, to connect. We know that social networks can, how shall we say, be the source of spread of adverse things, but we also know that social networks are also the source of spreading of good habits. You know, family connectedness is a social network. So social networks are powerful, and it's really the question now for the field to do research and advance on how we use them in a more effective way, either social media at the community level or in any new way that we, you know, in the next 20 years that we figure out.
I think we are out of time, but definitely if you had a question that I think a few of us in the panel will be here afterwards and you can come up and ask us.
Thank you very much. Please give our speakers another round of applause for their outstanding work on this. And please join us again in 2 weeks for another special session of Grand Rounds. Thank you.